of almost 70-75% patients are still on SU plus MET, and probably SU is there as a standard regimen there. And at the AD also they discuss what's the current role or place of SU in diabetes management and which SU would you choose. So I would start with Dr. Shashank Joshi here. What's the role of SU in today's management in patients with type 2 diabetes, and which one would be your preference today?
So I think, sulfonylureas, at least as far as India, Asia are concerned, they will never die. And even if you go to United States, even today you find that glyburide is still available. Glyburide is glibenclamide there. So there's a lot of non-insured population, Medicaid, Medicare population which still stays secretagogues. Now the old secretagogues, which are not available anymore, had all these deleterious side effects. In the modern era, I think there are two sulfonylureas, and I think Sanjay has done a lot of work with Dr. Sarita Bajaj on this, that the two modern sulfonylureas, particularly glimepiride and gliclazide, which have produced some elegant data to show that they are not as deleterious as before. There are only three challenges which are with sulfonylureas. Number one is they are not as durable as some other agents. Number two is that they have some amount of weight gain as a potential. And number three is that they can cause hypoglycemia because they have that is the way they work. So these are the three rate limiting steps. But for that, on the efficacy standpoint, on the ease of use and the rate at which they reduce glucose, it is pretty okay. Now, cost is a major rate limiting step in our population. You see, with the advent of Carolina last year, we clearly know that they also are not deleterious to the heart as previously predicted. So I think this is something which we now know. Having said that, across the world, the gliptinization has happened to a great extent, and therefore it is fast trying to get replaced by the sulfonylureas are getting replaced in the Western world, where reimbursement is a big challenge. But I personally feel that in the Indian context, Asian context, African context, South American concept, I think sulfonylureas are here to stay. The hypoglycemia is more of a function of education. For example, if you skip the meal and you take the pill, you are going to get hypoglycemia. If you eat half the pill, half the meal, take half the pill. So if you do a little education, you can handle these medications very well. As I said, the only challenge I see may not be so much of hypoglycemia, may not be so much of weight gain, is actually the durability, which goes away after a couple of years. That's something which we all know. And this is something which we recognize. I think it is time for us to probably do away with glipizide, glibenclamide, and most of us have done away with it. When we were medical residents at KEM Hospital, we used to actually have TBI, and chlorpropamide. And they were real oral pumps, and that chlorpropamide was a strong hypoglycemic agent. And people did very well with 30, 40 years. Today is, Dr. Asgavkar's father's birth anniversary, and I was just seeing that on the Facebook. He's one of the pioneers who started the first clinic of diabetes in Western India, in Grand Medical College. And he did all his titration with urine glucose with chlorpropamide. And for him, it was chlorpropamide or the old bovine insulin, which was short acting or intermediate acting. And based on that, they managed diabetes for almost 40 years. So these agents are here to stay. And I think, but their use has become much less because of gliptins, metformin, and SGLT2 inhibitors. And I think the hype on the cardiac implication, hypoglycemia implication has been a little overhyped. I think gliclazide had the advanced study and glimepiride has some, by default, a cardiovascular safety issue. But I think these agents are here to stay. We should not decry them. And I use them in my practice. Even today, I use gliclazide, I use the glimepiride very efficiently, very effectively in a large proportion of patients. And if somebody is well stabilized, has a reasonable A1C between 6.5 and 7, does not have hypoglycemia, and is not having any deleterious side effects, I feel it is reasonable to continue them unless I have a compelling reason to change. I'm sure other panelists might have a differing view, but this is my view. Thank you.
Thank you, Dr. Joshi. Dr. Sethi, your views on the place of SUs in today's world?
Well, Dr. Shank has very elegantly put across things. My only thing is that cost is a serious consideration across the world, and we are living in a impoverished and further impoverished world after COVID. If all things are considered equal, the inclination to use gliptins is more, or any other agent which does not produce hypoglycemia. In our context, it could be AGIs, it could be SGLT2s. I'm not saying that we do not use this, but the rung has slightly changed. We are not using a second line or third line agent. Maybe we choose it when we cannot do without using a hypoglycemic agent or drug that produces inherently hypoglycemia, like insulin versus sulfonylureas. That is a personal perception. The only concept there is of safety. Given that the only thing anti-sulfonylureas do is produce a rapid fall in the glucose, which for a disease which is going to run for years is immaterial. Whether you reach HbA1c in 3 months' time or in 1.5 months' time, it does not matter. So for the reasons of safety alone, we are beginning to use agents other than sulfonylurea. There is nothing against sulfonylurea as efficacy, not that they cause cardiovascular harm, not that they cause renal damage, but the simple fact that they may produce hypoglycemia. I am not luckily a diabetic, but if I become one, I will not use sulfonylurea as a second or even third agent. I'll be quite happy using any gliptin, and I treat my patient the same way as I will treat myself or anybody else. It's not that this approach is the best approach, but this is a personal approach, and it is doable. We have got gliptins which are now not that expensive. They may not be that good or that standard, but that is how we approach. We try to give non-hypoglycemic producing therapies, given that there are guidelines to suggest that choose an agent based on the efficacy, which most of the agents are equally efficacious at the HbA1c that we try them, and try to avoid weight gain or hypoglycemia.
Thank you so much, Dr. Siri. Dr. Sujoy Ghosh, your take on SUs today?
Right. Firstly, I'll try and talk about 3 presentations at ADA this year related to SUs. The first, the 2 of them were from the UK General Practice database. One comparing glyclazide with sitagliptin in terms of clinical efficacy, because time and again, we as clinicians believe that SUs are more potent than the DPP4 inhibitors and SGLT2 inhibitors, but clinical trials that these companies conduct, they try to tell you that, they are all same. This clearly, the UK GP practice data clearly shows that glyclazide is more potent than sitagliptin. So that's reassuring because it is in line with what you and I see every day in clinical practice. This is one study, and without increased risk of hypoglycemia. That's what this UK GP practice data clearly shows. That's one study. The second study is again from the UK GP practice, which has looked at people wherein you have used sulfonylureas as first line drugs because you probably had some compelling reason to not use metformin as first line. And they have compared that with people who were started on metformin as first line drug. So you have 2 groups of people, and you have looked at cardiovascular outcomes. They have looked at the cardiovascular outcomes, metformin versus first line SU. And they found that the SUs had higher cardiovascular events compared to the metformin group. But this higher numbers is actually accounted for the ones who are more obese. Whereas if you look at the relatively near normal body weight people, they did not have that increased cardiovascular risk. So what this database suggests is that if you have someone who is overtly obese, there might be some problem with the SUs in terms of cardiovascular outcome. Whereas if you're normal body weight or near normal body weight, this cardiovascular outcome risk is not increased. The third is a reanalysis of the Carolina data. And in the Carolina data, they have again looked at people who developed hypoglycemia in glimepiride versus linagliptin. And they have shown that obviously the glimepiride group had higher hypoglycemia. They now looked at the CV outcomes or the CV events in the trial in the linagliptin arm and the glimepiride arm. In both of the arms, it was seen that people who had developed more hypoglycemia that group developed more cardiovascular events. But interestingly, you did not have episodes of hypoglycemia preceding a cardiovascular event, essentially telling us that the ones who are developing hypoglycemia are probably patients who have other problems which predispose them to hypoglycemia and cardiovascular event, and not necessarily the drug triggering the cardiovascular event. It's like someone having an organ dysfunction. You have liver dysfunction, you have got renal dysfunction. So obviously this guy is going to develop more hypoglycemia, and this guy is also going to develop more of cardiovascular event. And the point that Dr. Shashank was making, that about the cardiovascular safety of SUs, because the 3 points that he very clearly mentioned was number 1, durability, number 2, hypoglycemia, weight, and cardiovascular events. These are the 4 things that SU have been continuously being blamed for. So in terms of the cardiovascular event, I have a paper which is currently in review. What I have done is I have taken the entire Carmelina dataset, I've taken the entire Carmelina dataset. So one, you have placebo versus linagliptin, the other you have glimepiride versus linagliptin. So you have A versus B, and you have A versus C. So I have done an indirect treatment comparison meta-analysis to show what would have happened if you had done the trial with A versus C. So that way we have shown that there is no increased risk with glimepiride as compared to placebo, because there is no heterogeneity in these trials. You've got only 2 trials that you are comparing, 4,000, 4,000, 8,000 patients. And it is clearly established, because you're not going to have a dedicated CV outcome trial for glimepiride or glyclazide in the future. I don't see it happening. So at least indirectly we've shown that there is no increased cardiovascular events, no all-cause mortality increase, no CV deaths. But like, I think I would have my balance between the views of Dr. Joshi and Dr. Sethi, in the sense that I'm quite happy to use a sulfonylurea as my second line drug, provided the individual is not grossly overweight, provided the individual does not have organ dysfunction and is sensible.
Thank you, Dr. Ghosh. Last word was good. Over to you, Dr. Kalra. You've been front with smart SUs and a lot of consensus on SUs. So your final take on SU's place in today's management.
The discussion by the 3 panelists has been wonderful, and altogether we know how to use SUs safely and smartly. So safe and smart use is what we say. If your patient suspects or anticipates or encounters hypoglycemia, your patient should be empowered to down titrate the dose. So if your patient anticipates hypoglycemia, today I'm going to keep a Tuesday fast, or next month I'm going to keep a Ramzan fast. That's anticipation of hypo. The patient should be empowered to reduce the dose by half. If the patient suspects hypo, there are symptoms suggestive of hypo, or the patient actually encounters hypo, the glucometer says that the glucose is low. Again, the patient should know how to handle. If we just teach this to the patient, that's fine. On a personal note, my father, he's now 76. He takes metformin and sulfonylurea, and he's happy with life. Touch wood.
Thank you. Thank you, Dr. Kalra. Thank you so much.